Thanks, Matt. I really appreciate the opportunity to give this talk. And I have two disclosures, which I failed to put on my slide. One is for Medtronics, and the other is for Orthopediatrics, both for spine instrumentation. I kind of have a different viewpoint on navigation and robotics. I really don't necessarily agree with some of the statements that were made earlier, and maybe we are saying the same thing, but I think it's just evolutionary. It's not revolutionary. It's really addressing the same questions we had before, which is where's my target? How do I get there safely? Where am I anatomically? And how do I position my implant? We all know this, but spine deformity surgery is really all about error prevention. It's a complex three-dimensional task. There's low rates of errors in general with what we do. There are extremely low rates of catastrophic errors, but we know that we can make it safer, more reliable, and using technology, we can certainly help to avoid catastrophic failures. And these are really not issues that are unique to spine surgery. They're unique for any kind of high reliability system that whether that be the military, nuclear power stations, nuclear aircraft carriers, or pilots. There's a really interesting series of papers, and there's a book written by James Reason. I think everybody's seen the Swiss cheese model of accident causation. I think it really started in 1990 with this guy, James Reason, who's a psychologist, and I would recommend, he's got some very short articles, and he's also got a book, and they're terrific, and it's really sort of the start of systematic evaluation of risk in essentially in high reliability systems. So very similar to the areas that he studied, which were nuclear carriers, power plants, and air traffic control. We're working in an interactive environment with time pressure, and we're carrying out demanding tasks. And most of the time we can do it without catastrophic failures, but occasionally those do occur. And I think that's where navigation and robotics comes into play. The most important features that Reason pointed out in high reliability organizations is a real preoccupation with the possibility of failure. I think that's really true, and it's true at HSS. I'm sure it's true at other institutions. It's basically every time you go into a case saying, what's the worst thing that could happen and how am I going to prevent that? And I think that's what robotics is all about. That's what navigation is all about. And I think they're both tightly linked, and I think there's very little difference between good navigation and robotics, because currently we are the robot. Our hand is the robot, and the robot doesn't really add anything beyond what we get from really good navigation currently. I think the future is probably going to be a little different. It's important to rehearse scenarios of failure, imagine different routes of failure, different modalities of failure. Basically, how can the technology lead you wrong and lead you astray? And anything that you can imagine, I guarantee you, and I know for a fact it's been done. So it's good to think that way, because most of the time things just go fine. One of the problems with technology is that people start to forget to be afraid. They think everything's pretty straightforward. And when you forget to be afraid, you get into trouble. This is a case I did probably 3 years ago. I do the left side, the fellow does the right side. And I'm not saying this, not blaming the fellow still. But we navigated the screws, we navigated the pathway. We took a ball tip at T7. We knew we had the right, and he just dropped his hand and dropped the screw right into the canal, lost all the motors. It took about an hour to recover the motors. We were about to take out all the implants, and things recovered. But even with navigation and use of a pediguard and having an appropriate track for your pedicle screw, you can have an absolute disaster. And so I don't think any of these things are foolproof, and these can happen with navigation, it can happen with robotics. I think the most important thing is redundancy, a robust system, and having multiple layered technology that's going to pick up your errors. And probably the most important thing with a high reliability system, I think that's true for this institution as with others, is you have resilience built into the system, or you're going to pick it up with some other modality so that you know that you made a mistake in terms of where you placed it. Planning isn't so you can have a perfect x-ray at the end, although that is the goal for most of us. It's when it goes wrong, do you recognize it in real time or before you have significant injury that's caused to the patient? So I think everybody knows how navigation and robotics works, but you're taking a 3D map. There are a lot of different ways you can register it, and then you're doing surgical guidance based on the 3D map. I think the most important thing with navigation and robotics is really what we learned from the total knee literature. When you start looking at mechanical axis of your total knees with robotically placed or cuts for the knees, you remove the outliers. So you take somebody who's got very little experience, and I think Dr. Lieberman showed a really nice slide where you can sort of show that you take somebody who's a beginner and they can function as somebody with significant experience. So I would just posit and say this, and I don't know if it's controversial, but I don't think that navigation and robotics necessarily helps a highly skilled surgeon. I think it helps when you're in a training center and an academic center, and it probably helps somebody who's on the learning curve to acquiring these skills, but it does certainly remove the outliers. And I'm not saying that because I'm opposed to navigation and robotics. I am completely 100% supportive of it, but I just don't think you can prove efficacy and utility of it if you take a highly skilled surgeon. They may, in fact, be slower with a robotic platform than they are. In fact, they will be slower with robotics than they are with navigation, and many of them don't require navigation. But it is an incredible layer to put on top of what you're doing in terms of safety. In terms of speed, most of the studies show that purely navigated surgery is faster. Certainly, you can get less intraoperative radiation for the surgeon, but I truly believe you're giving more radiation to the patient. And I know there are a lot of different ways you can measure it, but they're not very good studies that have looked at that. And probably you're not saving anybody. You're not saving the patient radiation. You're saving yourself radiation. And at some level, at high volume centers, there is a cost effectiveness that's been demonstrated. And that's whether it's 150 cases a year or 254 cases a year, different studies look at it. It all depends upon what you put in as costs. But at some volume, it becomes cost effective. We've been using navigation exclusively, meaning I have in our OR doing pediatric spine deformity for about 2.5 years. There's no question it's faster, it's safer, more accurate screw placement, and it's not even, you don't need to do a study to prove that. There's no question that surgical navigation is faster. It takes 5 minutes to acquire all your 3D data in the OR. If you did a pre-op CT, it takes no time to acquire that data. And you can easily place those screws with really a virtuous cycle of feedback that you don't get when you're doing it with a freehand technique. One of the things that I think is probably most important when you're in a teaching center, and probably anybody who does this knows this, but I think it's for people who haven't done navigation, it's important to realize it really is not a video game. You are doing the same surgery you do open as you're doing percutaneously, or you're doing it using navigation, or however you're doing it. And the analogy I would make is, do you ever get into your car and drive just based on the GPS and black out your windows? You never do that. You drive based on your visual cues and you check your GPS to make sure you're where you're supposed to be. I think that's the best analogy. I mean, clearly there are people who follow their GPS and aren't looking out the window and drive off the pier, and that happens every couple of months and it gets reported and you get kind of funny story in the newspaper, or not so funny story. I do think that I guess I'd say the learning curve for the freehand technique, I don't think is equivalent to the learning curve with navigation. There's just no comparison. Having done one for 20 years and another one for 2.5 years, the learning curve with navigation added is so much faster. And I see it with the residents and the fellows on a week-to-week basis. So with freehand technique, you can see T7 pedicle screw, it's dropped into the canal, lost all the motors, eventually took it out, takes a ton of stress on the surgeon. A lot better in terms of sort of a virtuous cycle of feedback is line it up, take a look, see what your trajectory is going to be, and before you drop that screw into the canal, see that you're in the wrong position and avoid that problem. You've got the same learning feedback that takes place, but it's much quicker. And in terms of safety, it's obviously much better for the patient. So really what this amounts to is it's kind of layered technology, multimodal. I don't know what the right word is for it, but you can see we started with basically open technique, freehand technique, knowledge of anatomy. We added fluoroscopy to it. We added navigation to it. What is robotics? It's just the robots replacing my hand, which is holding a drill guide. There's nothing more to it. It's not, there's a lot you can do with it, and there's a big future ahead. And I do think it's valuable, but it's just one of many different techniques. And you can't forget, it's all about the safety net. You can't do this in the absence of having some other technologies to verify position of your implants, whether that be just palpation with a ball tip probe, use of bipolar electric conductive instruments, pedicle screw stimulation, or whatever other technology that you want to use. There are a lot of errors that take place with navigation and robotics, and I think it's anybody who's getting into it or just starting to get into it needs to know this and needs to know every different type of error that can take place. So registration, frame stability, that's the most obvious thing. Obviously, if you hit it, you're off, but you really are off, and you have to be aware of that. And so it takes it's a different thought process when you're in the operating room. Spine stability is an issue. So the Maser X grabs the spine in two different locations, tries to create a stable platform for where you're working. But even so, it's relative stability. So there's deflection of the spine when you press against it with a drill guide. When that moves, your navigation's off. So if you're not aware of that, you can get into a big problem. There's robot stability, and you can see that on the bottom image. And so there's connections between the robot and the patient, the robot and the floor, the robot and the operating room table. Skyve is probably the biggest issue with this, and that's true for navigation or robotics, and it's a huge problem. It's not a small problem. It's a problem for people with freehand techniques just as much. If you trust your nav, you think you're where you're starting your drill, but you're not always. And so that's probably one of the biggest factors, and I think you just have to be aware of that every time you put a drill against bone to put in a pedicle screw. And then there's all sorts of OR line of sight issues, whether it be somebody blocking your view of the screen, blocking the camera, not being able to get the 3D data that you need because of how you set the room up. There are a ton of studies that have looked at meta-analyses and systematic reviews. I just looked at a couple, and this is from 2019. It's probably the largest one, but I don't know that for sure. More recent. Definitely shows that CT nav and robotic nav are more accurate, lower breach rates on post-op CTs, and lower, sort of lower revision rates, not statistically significant. But I'm just going to point out there is no improvement with robotic navigation versus freehand navigation. So if you think you're getting something more accurate by doing it, you're not, and I don't believe that you are at all. That being said, there's a lot more that you potentially will be able to do with the robot. A couple of other studies that looked at this, screw complications seem to go down when you have more accurate screw placement. That kind of makes sense. The only caveat I would point out is that all the databases that generate this data are non-audited databases. The SRS study, the SRS database, the harm study group, people don't submit their disasters and their catastrophes. So if you trust that, that's on you if you believe that those are the real numbers for major complications, because they're not. And every center has their own, and every center has ones that go elsewhere. So I think that the data for complications for what we do are severely underreported. And that would make the argument for navigation and robotics even stronger. Cost effectiveness, this just depends upon how you look at the costs, but anywhere from 150 to 250 cases a year, people make the argument that robotics becomes cost effective. It's really interesting when you look at the learning curve data. There's different ways of looking at it. I mean, obviously, when you look at just at surgical time, and this is not for spine robotics, this was for some other robotic surgery. I forget what this, micro and endoscopic discectomy. But it's true for all the other studies that have looked at it. It sort of drops over time and it sort of flattens out at some point. Dr. Lieberman, I think, has quoted a number of about 30 cases a year. Other people have come up with a similar number. There's a more sophisticated way of looking at it, but I have to tell you, Madison, who helped me write this paper, is a BS, I guess, and she knows a lot of statistics. This isn't time, but it breaks down your learning curve into different segments. And really what's going on in the first phase is you're getting faster and faster. Then you're sort of static. And then as over time, you sort of are getting even faster. There's a third phase. And apparently, this is the most sophisticated way to look at learning curve, but I truthfully do not quite understand it. So I put it out there because I think we're just jumping into the navigated and robotic world, and this is probably the way we should be looking at it, but it doesn't inherently necessarily make sense to me. But you can see that different surgeons have different learning curves, and so everybody comes to this with a different background, different experience level, and so you go through the learning curve at different rates. I truly believe that how we train people to do this probably can greatly affect the learning curve. So if you know how to do navigation before you do robotics, you're going to get it a lot quicker. If you know how to do robotics before you do navigation, you'll also pick it up pretty quickly. The combination of the two, I think, is really, really something important and has a lot of safety features. So what's the argument for robotics? It's potentially more than just a drill guide. If it's just a drill guide, you and I don't need it. It's anybody in this room who does spine surgery doesn't need it. I think it's the other procedures that you may be able to do that are important, because it's going to take you longer, it's very expensive, and it's not more accurate. What's the concern? I think the biggest concern is that if you do purely robotic spine surgery, you are going to lose your sort of, not you, but your trainees are going to lose the freehand skill set. It's a different type of haptic feedback when you're using a drill as opposed to a lanky probe and a ball tip and other things to check your position. And then the question is, if you're a CHOP and you're doing pediatric spine and the power goes out or the robot or the arm's not working, you cancel your case. Is that appropriate for your patients? I'm not sure that is. I certainly would hope that that's not the standard of care. But I do think the robot, and the other disadvantage, I think, is if you just have a robot and you trust the robot and you start not to use your manual feedback, you don't really have redundancy in terms of safety. So what's the best practice in an academic environment? I think it still is stepwise skills acquisition. You need to have the freehand technique, whether you learn that in the lab, the cadaver, even in the OR. My philosophy when it comes to the nav and robotics is that you have to combine the two. I think you certainly should be doing both on every case. And if you've got trainees, you need to be doing both. I do think you need multimodal verification of trajectory. And does that mean you use a Pediguard? I don't know. If you've never used it, you probably aren't going to be familiar with it, but that's a great way to assess where you are. And it's a second check on where you are in space, but there are a lot of other ways you can do that as well. But as long as you've got multiple methods for doing that, I think it's important. I said it's unclear if the robot offers advantages over navigation. For pedicle screw placement, I'd reverse that and I say it's pretty clear it doesn't offer any advantages. But I think there are going to be some applications that will require a robot. Navigation is clearly safer, it's more accurate, it's cost-effective, it's some volume of cases, and navigation is, there's no doubt it's faster than doing it for open cases for sure. For pediatric deformity, you can put in your screws in, seconds as opposed to minutes. It's not comparable. Most important, I think you need redundant systems to prevent catastrophic failures. In terms of sort of outcomes analysis, I don't know. I think the things we look at is how accurate is your screw placement, what are the complications, neurologic injury rates, revision rates, speed in the OR. Does it make you so slow that you double your surgical times and your infection rate goes up? I don't think it does, and I don't think anybody's suggesting that it does. I think on every one of those, patient safety and complications, navigation and robotics comes out ahead of anything else that we do. Radiation dose plus minus, I don't think you can take that. There's no way that you can argue that doing a pre-op CT is less radiation than doing an intra-op spin with a Zeem under minimal radiation. On the other hand, your added safety and avoidance of a catastrophic failure is hard to weigh the two, one against the other. Cost analysis we talked about. And then there's the question of safety and ethics. Is it ethical not to use navigation in the OR? I would say it's unethical for us not to be using it. I think every single spine OR needs to be a navigated OR, and I've said that before, but I'm more convinced of that than ever now than I ever was. And that's it. Thank you.